supposed to do yourself before you cater to anyone else? Well, the heart has its own mechanism where it's oxygenating itself so it can function to supply oxygen to the rest of the body. And that's a key concept. And how it does that is through the coronary circulation. So the coronary sinus is the vein that comes back and drains into the right atrium itself. So, because it needs to get oxygen as well. Does that make sense? So, those three vessels go through the right atrium. Then we go through this door, because all these chambers are rooms. That's what a chamber is, correct? I'm thinking that we can leave the cardiac cycle for the next exam and just learn the anatomy and the blood flow for this exam.
Right.
Isn't that a good idea? I want to do my notes. So we all have the first half of the routine. Once it starts getting into SA known, AB known, and firing and stuff, PPRS, EKG, like how much we know that really well. All right. So the three vessels going into the right atrium. So I want you to always think of these atria and ventricles as chambers or rooms. So in this classroom, it's kind of like jail. Don't ask me. It's like jail. You walk in and you can't have two doors open. For those of you who don't know, you can't have two doors open in jail at the same time. Like you walk in and the door behind you closes before the one in front of you opens. Why? You can't escape, right?
Right.
It's like less room for escaping. Well, think of chambers in the heart as jail cells, because that's our jail door mechanism. That's the main thing that's happening. It has to close the opening prior before it opens and pumps you to the next chamber. So until this room fills, so pretend that window was our exit that we were going to, and this is actually our entrance. So we're a chamber, we're the atria, and the vena cavas are pumping into here. So once this is open, this kind of just fills in. Then this closes, and then that one opens. And then we all move out, because we're blood particles. But they don't list the valve just going from the into the right. They don't. There has to be one. There is. So the valve is your door. Anytime you see the word valve from now on, you just think, oh, door. Now, do doors shut? Do doors make sound when they're shut? Yes. Do doors make sound when they're open? Not if you have enough stone. Technically, no, right? She's open. So the heart sounds are coming from valves closing.
Why do you always point at me?
That's a test question. Anytime I'm thinking of what's on the test, I'm thinking of you.
Okay, good. Well, you help me too.
So heart noise is 25%.
So closure of valves are what's going to make the sound. And it's not the closure of these valves that are coming from, gravity that are just kind of going with the flow. It's the exit valves. So it's the semi-lunar ones. It's the one that's going from the aorta to everywhere. And it's the one going from the heart to the pulmonary. That just makes me think of a mistake I wrote on here. This is supposed to be semi-lunar valve. I'm so sorry. AB means atrioventricular, which is your bicuspid and tricuspid. Semi-lunar is exit valves. Sorry about that. So all they are talking about is the way the valves are made. So the doors have cusps, which are these, what are cusps? They're like cups, they're like flaps. So there's 3 flaps on the tricuspid, and the bicuspid has 2 flaps. Also know that it's called mitral valve, which is your typical term for that bicuspid valve. And know that that one, right atrium to right ventricle, on the right side is your tricuspid. So all we did was going back to the right atrium, close that door or valve, go through the tricuspid to the right ventricle, and then we're going to go to the lungs through the pulmonary semilunar valve. That's the exit to the vessel that goes away from the heart. So the pulmonary valve is the entrance to the pulmonary trunk. What color would the pulmonary trunk be depicted as?
Blue.
I'm getting that hard, right? So y'all want to know that that's very important. So the pulmonary trunk is blue because
Deoxygenated.
it's deoxygenated. Another term for saying deoxygenated is what? Carbon dioxide rich. Just in case you don't test for it, that's no. Same thing, right? Because if they're opposites, we're doing the opposite of the function of your reference point there. Whether or not it's oxygen or carbon dioxide, it should still be blue or red. Understand? All right, so we get to the pulmonary trunk, pick up that oxygen. We're going to come back to the heart via two veins on either side, and we're going to come back all the way to and it's not this far because the lungs are adjacent, so it didn't have far to go at all. So we come back to the left atrium. The left atrium then closes or shuts off and then opens up the bicuspid valve called the mitral valve, and the bicuspid has two flaps. So which would you think has more defects? The one that has three valves or the one that has two? Three. The bi is weaker, unfortunately. So we see a lot of things called mitral valve prolapse is one of them, or mitral valve defect. MVP, not most valuable fighter, but mitral valve prolapse. And what prolapse means? Falling out, like it just fell out. So there isn't such a thing as vaginal prolapse, uterine prolapse. But do your taking. Right now. That will prevent it. Too bad we can't really do that to exercise our heart valves because then that would break. But what happens is the actual valve itself comes into the chamber, which is the left ventricle. Now let's think about that. This door had a defect. Remember, the point of a valve is to prevent backflow, correct? Because we're trying to contain all this blood. The minute that we pump it, we're trying to inject all of it at the same time, not creating any backflow. But if this door is a defect and it doesn't close all the way, what's going to happen? We're going to have some leak out. How efficient is that going to be? Over time is not going to be efficient. Your heart's going to have to work harder to pump out the same amount of blood volume because it's almost having to pump twice to do the same job as someone without prolapse. So that's our mitral valve prolapse. Anyway, so we came from the lungs to the left atrium, through the mitral valve, into the left ventricle. And this is the body that has the most myocardial tissue, or the chambers that have the thickest myocardium. And it's because it needs to do this huge pump. So it ejects it through the aortic semilunar valve and through the aorta. And we'll talk all in chapter 19 about what happens then, because it goes throughout the entire system. And then we drop off that oxygen, and then we come backwards through three vessels, and we do it all over. Everybody good with blood flow? Okay, let's talk a little bit about some things anatomically within the heart. Okay, I'm going to try my best to be a good heart. But within the heart, if we were to do, there's my heart. So remember that the heart is between the third and the fifth intercostal, or the first and fifth intercostal space. So if you ever do EKGs or anything like that, you'll kind of be able to identify where the sleep cells, where the heart is. The apex of the heart, and for some reason this is a FMQ. The apex of the heart points where? Better terms than that, Corey. Come on now.
Superior.
The apex points where?
Yeah.
It's home. Oh, Lord. Oh, that's not what's not. No, you know it. There's a point. It's on the bottom, but where is it pointing to? About axillary?
Sure.
Right?
Good.
So technically the left axillary, right? So I would say the closest area to the apex of my heart would be kind of left axillary region, big intercostal space. Is that about right? Yes.
Yes.
No. And I was confident about that. No, not much. I would say. However, is it part of the test question? It's important to know. So that tends to be something that we end up forgetting because the apex in regular general terms usually means the top. So remember that the heart's apex is on the inferior side and it's pointing to the left axillary. And your heart itself is not extremely midline. So you can't have a sagittal cut through the mediastinum, which is the area of your heart, the cavity that your heart sits in, and say that you'll have two equal parts, right? Because of the way it sits closer to the left side. Cool? Alright, so the third and fifth are your landmarks. Third and fifth intercostal spaces. And the sounds of the heart are made up of, and this is technical term, love dove. And the sounds, what do we say? Mid sound? The closure of valves. Which one? The exit valves. There are two of them. We're either going to the heart, the pulmonary semilunar, or the aortic semilunar. So the first love is going to be going to the lungs. The second love is the aorta, or dove. Sorry, love dove. And I think they always do love dove. I never understood that.
The love is going to
The lungs, and the second one is going to the aorta so that we can cover the system. Cool? Anatomically, if we were to take apart the layer of the heart and the pericardium and actually do a coronal cut, which is how you see the heart visualized in every picture, you would see the atria, the ventricle. In between, we call that piece of myocardium the interventricular septum. And if we're dividing the lateral portions of the atria, we call that the intraatrial septum. So interventricular or interatrial septum. What is a septum? A division. So where do we have a septum? Nasal septum. That's the if we could continue the bridge of our nose, that's the septum that divides both chambers. That's exactly what the septum is doing between the atria and ventricles. So you can see that in the coronal or frontal cut of that. So you can see a right and left on that situation. So when you look within these chamber walls, whether or not we are atria or ventricles, our muscles will have indentations. These interior walls will have indentations. So the endocardium is going to have this trabeculae. Why are you not giving me looks? Where else have we seen trabeculae? There. The bones. Excellent. Michelle say Joe. So, Spongy bone, excellent. Who was that? Who said that? There was Eric. See, it was there. So spongy bone had the same trabeculae, and I want you to visualize what it looked like. And it looked like just projections of bone under a microscope. That's the same type of trabeculae carne that's in cardiac muscle. So trabeculae carne. And what's carne? I think it means flesh. Like meat, yeah. Carne is meat. So trabeculae carne is the indentations within the muscle. Now we have projections or elevation of muscle to where our cusp, tricuspid and bicuspid anchor themselves too, and that is known as papillary muscle. So papillary muscle is where the extensions of our cusp anchor themselves to. Let me have a good picture of that on our slide. I don't think they do.
Extension of cusp.
I think it's like maybe towards the AV valves.
Towards the front, you can see all that material that's like
Yes.
stretching and holding it.
So let me tell you that these cusps look like that, right? And that's just a singular one. And it has extensions or cords called chordae tendineae. And you know, this is Latin, so we add an A and E on everything a lot of times in anatomy. Chordae tendineae get attached to the projections of the wall called papillary muscle. If you didn't know what that was, it would look like jellyfish.
With shoes on.
Alright, so papillary muscle, chordae tendineae, and this is a cusp. So these are going to be present in atria or ventricle.
Both.
They're in ventricle.
They are in ventricle. Because remember, the blood flowing from the atria is going to go through here, but these cusps are anchored in the ventricles themselves. So the valve doesn't move per se. Okay? So that's that. We looked at semilunar. Alright, so we're not doing physiology, but let's talk a little bit about what a myocardial infarction is, which is an MI.
So the papillary muscle that anchors the
Sorry.
tricuspid.
No, that's all right.
Don't worry. Yeah, you're good.
I'm fine.
Somebody
No,
take it down.
I'm recording.
Occipital.
But it anchors it, right? The papillary muscle anchors it to the ventricle.
Yes. Yes. So trabecular carne is throughout the atria and the ventricle. Papillary muscles are the projections that anchor the chordae tendineae, which are part of the cusp themselves. So I would say that that's a big FMQ, papillary versus trabecular carne.
Okay, we go over. Yeah. Those ones.
The trabeculae carne is just going to be present throughout the chambers of the heart. So both atria and ventricles have that. They're more like,
What's yeah?
yeah.
Like on the test with yeah.
Trabecular carne is fluffy tissue. Fluffy tissue.
It's bumpy.
Bumpy. Yeah, they're bumpy projections. Papillary is the anchor or the projection of the ventricular walls. And the chordae tendineae are the cords that are attached to those anchors. And they come from the cusps. The only two we have, tricuspid or tricuspid. Okay, which one is called bicuspid? Mitral. And the one on the left. Excellent. I learned so much in like 20 minutes. And if you throw some kids into the mix, they'll do it fast. Try like 7. Okay, so we did the heart sound, we did the capillary muscle. Okay, let's talk a little bit about MI. I want to address that. So, just like we had pulmonary circulation and systemic circulation, we also technically have another type of circulation, and that's the coronary circulation. Coronary means heart itself, okay? And I don't want to go into detail with the vessels of it, but basically we're coming back via a vein called the coronary sinus. So the coronary arteries feed the heart myocardium oxygen, and the coronary veins go back and become the coronary sinus, which drains into the right atrium and reoxygenates itself as well. You all with me? So coronary sinus, having a blockage there would lead to decrease of oxygen to the heart myocardium. And that is known as a myocardial infarction. With a C in there.
So are these veins like where? Are they on the outside?
They're on the outside superficial surface of the actual heart itself. Because this is the tiny little vessels that supply the heart itself. So if I were to have a myocardial infarction, what are my clinical signs for that? And there's one huge one. Chest pain. Technical term? Myocardial infarction is a heart attack.
Yeah.
What's a sign of a heart attack? She said chest pain. What's the term for that? Angina pectoris. So, angina pectoris is a sign of an MI. And all that is chest pain. Just terminology. So, ischemic means lack of oxygenated tissue. So a myocardial infarction leads to ischemia. Is that safe to say? Because there's something there, and we'll talk a little bit after the test when we have some time, where it's really inflammation now that they think, because prior they were saying it was cholesterol, but it's not cholesterol now, it's just inflammation of that tissue that causes blockage or impedes blood flow. So that's that. Are we good? Woo. So no physiology of the heart, just the anatomy, and just focus on whatever I wrote on the board and said out loud.
You do that.
You need to say that. We should know the heart then.
Yes, you should know the heart well.
Is that going to be lab?
Yes, lab would be labeling the heart very well, but lecture would be describing.
But are you doing heart lab?
Yeah. No.
No heart lab.
Yeah.
We just know it for
Lecture. It'll be on our test.
It'll be the next lab.
Got it.
Because I combine lab, heart and blood vessels, because they kind of go together, and that's a huge list. So we want to keep that separate. Correct. Oh, you took some, right? That's better than what I wrote on the board.
Should I? Can I?
Yes.